development matters. If for you, if for me, development matters. Development matters.
Hello and welcome to Development Matters. On the program today,
nothing under the sun is free. Not even healthcare, or I would say especially healthcare.
we discuss healthcare, more particularly healthcare financing.
So I think this is the right time for the government to begin that process of making the Liberia Health Equity Fund a reality.
Also on the program,
A kid, 10-year-old kid walking from Coward to West Point, probably 1 or 2 hours.
we profile a Liberian whose life story is a powerful testament to one's ability to succeed against immense odds. But we begin with healthcare. The 2014-2015 Ebola virus disease outbreak exposed deep weaknesses in the Liberian healthcare system, a lack of adequate facilities, and an acute shortage of trained medical personnel. Efforts to deal with these problems often run up against a persistent reality: lack of adequate funding. This thus raises the question, how do we as a nation secure funding to give all Liberians access to affordable care? To discuss that topic with us today, we have three people who are very much familiar with the health sector. First, we have Mrs. Ya Matozolia, a former Deputy Minister of Health for Policy and Planning and currently a private health consultant. We also have Mrs. Elizabeth Mulba, a former President of the West African College of Nursing and former Deputy Chair of the Governance Commission. Finally, we have Dr. Mosoka Fallah. He is the Deputy Director for Technical Services at the Liberian Public Health Institute. So, what are their key recommendations? Well, they say we must first come to grip with something we often take for granted, that there is a cost to providing all Liberians access to affordable care.
How to secure quality funding for healthcare in Liberia is first of all to accept the fact that nothing under the sun is free. Not even healthcare. The facilities we run, the health manpower, their salaries and benefits, the equipment and logistics, until we decide or agree to cost all these things here. And of course, the cost of drugs that an individual patient receives upon coming to the hospital or to the health center, that we cannot begin serious and productive discussion on the question of healthcare or how to fund and provide access to healthcare.
Just as my colleague said, free healthcare service is actually not free. It is at no cost to the beneficiary. Somebody is paying for that service. So when the government took on the initiative to institute the policy, the government was in essence saying that she was going to bear the burden of paying for the services.
Our experts note that the pretense that healthcare is free often leads to more harm than good.
What my experience has seen is that where we have declared free healthcare, at the end of the day, it becomes more costly. And this is what I mean. Because it's free healthcare, the patient goes to the hospital. There are no drugs to serve. So the doctors, against their will, most of the time, have to give prescription. The patient goes outside. They don't know that some of the medicines they buy off the street, or even if some of our pharmacies are outdated or counterfeit, they go ahead and buy, and the next time we see them at our health post, they are worse than they were when they came first because of the effect of the outdated medication or counterfeit medications that they have used.
In addition to realizing that healthcare is not free, our experts say that the next step on our journey to securing adequate funding for a national healthcare system is to figure out how much we currently spend as a nation on healthcare and the various sources of that funding?
The total health expenditure, according to one of our studies that we did in 2013 to 14, when I was still in the health sector, it shows that when you put all of those expenditure together, what government is paying, what the donors are giving, what people are paying from out of their pocket, what the private sector is paying, it was close to $300 million. Annually, $300 million total health expenditure. Of that amount, 42% comes from people's pockets. The amount is 42% of that 300 million. So in essence, that's what the population is contributing out of their pocket. When it comes to the donors, the study shows that the contribution was like 39% from the donors. And then the government contribution was 16%, and then the private corporations contributed 2%. So in essence, that's a snapshot of the landscape of financing of healthcare.
According to our experts, the 42% of the health budget that comes from private pockets is relatively high by international standards and very regressive.
Another issue with this free healthcare, like I said, is the high out-of-pocket payments. So we have a system where it's supposed to be free, but the population is paying heavily out of pocket. And it leads to catastrophic expenditure. And this out-of-pocket expenditure is regressive. Regressive meaning those who are in the lowest wealth quintile, the poorest people in Liberia, pay as much as those who are in the highest wealth quintile. If somebody is very poor, they're paying almost as much as somebody who is very rich.
Our experts also complained of what they call inequities in the healthcare system that favor the rich.
There is a poor-rich bias when it comes to the subsidies that the government gives to fund healthcare. What do I mean? The health centers and the hospitals, they receive a greater proportion of the subsidy that this government is supposed to be giving to the sector. And who access the hospitals and the health systems, the health centers most? It's the rich people. The poorest people are in the villages. They are the ones that access the primary health care system, the clinics, etc. But majority of the subsidy for funding the free healthcare goes to fund hospitals and health centers. So it's the rich people that are benefiting more. We did a study in 2010 called a benefit incidence analysis that shows that it is the rich people that are benefiting more from the government subsidy that goes to the health sector.
The experts we're talking to also identified yet another problem that they say we must bring under control before we can talk about how to effectively fund a national healthcare system. That problem, the huge inefficiencies in the way Liberia now currently allocates funds amongst the counties for healthcare.
In terms of efficiency, there is unequal distribution of the allocations that go to the counties. It ranges from $32 in the lowest the county that receives the lowest, to $89 per person. That is how the disparity is. So you have some counties that receive $32 per capita for health care, while other counties receive $89. Our allocation is not informed by the disease burden, is not informed by the population, is not informed by the geographical location. Rather, it is based on which lawmaker is able to make the loudest noise. So you allocate monies to the counties based on who has the loudest voice. It's not scientific.
Mrs. Zolia also says another problem with healthcare spending is the way donors' money is spent.
Another efficiency issue with the donor funding, remember when I gave the previous statistics, I said close to 70% of the public finances comes from the donors. Of that 70%, more than 46% is off budget and off plan. It means that it does not go to fund priorities in the sector.
Yet another issue our expert identified is the long-term sustainability of the way we now fund healthcare, given our heavy dependence on donors.
The last issue with this free healthcare is that even though the donor community is heavily funding this free healthcare, in the long term, it's not sustainable for us as a country. We're heavily donor dependent. And so it makes the system very vulnerable to any external shock.
Sure.
Today, if there is news that the global funds will no longer be funding Liberia, we will not have drugs for malaria, mosquito nets will not come, medicine for preventing malaria in pregnancy will not come. So that's the kind of reality we're faced with as a country.
So, given this background, what are the key policy recommendations for helping Liberia secure the funds it needs to finance a national health system?
First one is how to make more efficient use of the available resources. Okay? One of the ways we can make efficient use of the available resources from the government side is to institute what we call resource allocation formula. The ministry, I guess, is working on it. When I was there, we started the groundwork for that. So it's a formula that will take population, disease burden, geographical location, terrain, all of that into consideration in calculating allocations to counties. If you do that, the money will be targeted at where the problems are. Mm-hmm. The second way is this huge donor funding that we are getting. How do we work with the partners so that we can align all of their activities and their plans with the government's priority? We started a compact called the IHP Plus Compact, which commits all of the partners towards aligning resources to national priorities. Once that gets implemented, it will take care of the efficiency issues and help to make better use of the resources that the country has currently for health.
These measures, as former Deputy Minister of Health Zolia noted, will certainly take care of efficiency issues, making sure we use available resources wisely. But there remains the outstanding question of how we get more resources, more money into the healthcare system in the first place. What can we do as a nation about that?
Moving forward, the nation needs to begin to seriously start discussion on what we have coined the Liberia Health Equity Fund. This is a prepayment insurance scheme where resources are mobilized from all of the sources we just named, from the government through the allocation and EMR taxes, from citizens through premiums. So in the formal and informal sector, you can collect premiums, and then from the donors. And this can be pooled in a basket. And then you can now strategically purchase healthcare delivery both from the public and the private. So this time around, everybody will be bidding for that basket fund.
Pursuing this model, she says, will allow us to do a number of critical things that are essential to securing long-term health financing.
The first thing is you will be mobilizing additional domestic resources, because remember the 42% that I said previously coming from out of pocket now will be channeled through that pool. And then those who can pay will be paying, and those who cannot pay will still be subsidized from that pool. So you have your poor people, you have maybe your pregnant women, your children under 5. There can be some exemption criteria for those people who, the government wants to exempt. And then you can in that way you will be able to cross subsidize, those who have more money who are paying can pay for those who don't have. And people will not have to pay before you get treated because the system will be in place to take care of you.
This system, she says, will produce competition among healthcare providers, forcing them to provide the best possible care at the lowest possible price.
In that way, you will be reducing the out-of-pocket expenditure that we just talked about because you will have a clear mechanism of collecting, a formal way of collecting it, which will reduce the burden. And then you will have competition in the sector where the public and the private will be competing for that money. So the patients will have a choice of where to go. And in that way, it creates a healthy competition. So everybody will want to improve their services to have good service so that patients will come because the more patients you get, the more money you'll be paid as a result of that.
Under the model Mrs. Zolia is talking about, once you take away the money the government and donors spend on healthcare, there's really going to be only one new additional source of money.
The new one now will be the additional monies that people will be paying, the premiums.
A potential problem is how do we get people who are not in the formal sector or who are not employed in the formal sector to pay their premiums to be part of the insured pool.
For now, what studies have shown is that it will be a bit easier to get premiums from the formal sector, people who are employed in the formal sector. For the informal sector, in Liberia, even though the informal sector is kind of informal per se, but there is some level of organization within the different sectors. You have women groups, you have the bike riders, all of these different sectors are groupings that you can use to be able to get their members to contribute.
Are there examples where this model has worked, and what can we learn from them?
Thailand is a good example that have achieved universal health coverage out there. What they have done, they call it the 100 baht, which is US dollar. Everyone pays the US dollar to get insurance. So there's a concept of opting in and opting out. And you look at the alternative. If you pay, say, $10 US, even though you're a world market seller, you pay $10 US and you went for local treatment and your overall cost for payment is around $5. However, if you decide to opt out and you went for treatment in our scheme, you have to pay $50 US. So that's a kind of control knob. If I opt in, I pay less. But if I decide to stay out, I'm doing it at my own risks and my family risks. That's one we can get in. You can incentivize, we call it in public here, notch the informal sector to start to make some payment.
He says Cambodia also provides us a good model.
What I was doing in Cambodia is that they did a comprehensive database to first of all establish the poverty index. They created a poverty index. They did a comprehensive database to understand the economic condition of the country. Once they have established the economic condition of the country, they already know that they're exempt. And they have a way of knowing, for example, Legis does that. If you have a thatched roof, you have a debt flow, you are putting certain wealth quanta, you are poor. Those people, so first of all, it has to be going by empirical evidences, comprehensive data that will look at the household level, the income level. You have that already established. What Cambodia did, just like you said, they took, USAID was a good proponent, they took the USAID fund, private insurance all came together with local NGO. Then they had the university develop a strong monitoring system. And then they went into the various subsections of the country and hired local NGOs to be responsible for, say, the hospital in this geographical area, to ensure that the payment is done, the records are reviewed, and you're doing effective monitoring system, that the issue of inefficient allocation does not comes about. And so it's going to be that opting for the informal sector, building a strong database, pulling the fund together, and a strong regulatory mechanism must be in place.
A couple of additional points our experts make is that we must be realistic about the kind of care we can afford under this model.
If we provide universal insurance to our patients, what type of care can we cover? It's going to be fundamental. Can we create this insurance and let people do brain surgery on it and do kidney surgery on the basic insurance.
No.
It has not worked anyway, right? There is a basic insurance that it covers in the package. And then what happens in Canada and other countries, then you can take additional insurance as a buffer if you must do more specialized. Because now this is a pool, we're pulling the rigs together. We can't pull this rig together and do all conditions at the same time, all specialization. We got to say, okay, what we do 1, 2, 3, 4, 5, 6, 7. These will be basic that will provide under the insurance scheme. But if you anticipate that you want to have such specialist care, you got to pay a little bit, so other people would be able to take out other insurance.
Another point to stress is the need to reduce cost by emphasizing preventive care.
We could save a lot of money. In one country that have done so well have been countries that have invested in primary health care. And be able to prevent. So by prevention, the total number of patients that even go, so that we're talking about issue of non-public health intervention. What that does is that it even reduces the load on the doctors in the health facility. So if I was supposed to see 200 patients and 100 of them are diarrhea disease because they're not drinking clean water, but this time around we improve the water system, we treat the mother better. So now I'm only seeing 50 patients. I can spend more time with the patients and give them better care and incentivize them to come. So one way is not addition, it is a subtraction, but in essence it gave us money by investing in prevention.
So, if we do all of these things, can we really put in place a credible financing system for healthcare?
Done all of the work. Our weakness is not taking that policy and implementing it. But all of the work nobody has to reinvent the wheel. They have done very thorough job, how to access funding. They've done study again. So it's anyone who can take what they have done and implement it is possible.
And they say this is about the most opportune time to implement the policy to ensure sustainable funding for healthcare delivery in Liberia.
In the current political landscape is a very good opportunity. When we attended a health financing course in Washington, we were told that any reform that you want to undertake, it is best for a new administration to begin it. You don't begin a reform in the middle of your administration. So this government has the perfect opportunity. And the Liberia Health Equity Fund is a pro initiative or mechanism where you pool the resources and those who cannot pay, those who are poor, will be subsidized, either by those who are paying more or by the government. So in that way, you reduce the burden on the poor. So, like he said, the time is now for the government that has the mandate, to take care of the health needs of the population, to take on this responsibility. And, all of the players are there to work with the government to be able to see that it happens. So I think this is the right time for the government to begin that process of making the Liberia Health Equity Fund a reality.
Development matters. Development matters.
This is Development Matters. When we come back, we profile a Liberian whose life story is a powerful testament to one's ability to succeed against seemingly insurmountable odds.
Yeah, we need good health care, good education for everybody, yeah. We need gender equality and public accountability. It matters for me, it matters for you, because anything we do, there's nowhere like home. It matters for me, it matters for you, because anything we do, there's nowhere like home. Development matters, development matters. If for you, if for me, development matters, development matters. Gotta try to make a change, it matters for you, it matters.
It is a life that took him from West Point, one of Liberia's poorest slums, to some of America's leading universities.
This is where I used to live. My mom, my dad, and my sisters and I were all in one room.
Things were tough, and many times the family could not afford to send him to school.
Then the first semester, we couldn't afford it, and we didn't go to school.
When he did go to school in faraway Caldwell, he had to walk miles and miles to get home.
As a kid, 10-year-old kid, walking from Caldwell to West Point, probably 1 or 2 hours.
But he persevered, and with the aid of scholarships, graduated from high school and then the University of Liberia. Then, with the help of some friends, he made it to the United States for graduate school.
My parents couldn't afford it. My friends in America actually raised my plane ticket. Someone will give $100, another person will give $50 to buy my plane ticket to go to the States. I went first to Kent State. I should have done a master's in 2 years, but I was so fast to learn, so I did it in 12 months. Then I went to University of Kentucky to do my medical school, do my PhD in microbiology and immunology. And then I got accepted to go to Harvard to do global health, and I did infectious disease epidemiology. So it's a long road from now. I want to cry, in fact. It's a long road from here.
He returned home not too long before the Ebola outbreak that hit his very own West Point very hard.
When Ebola hit West Point, for me, it was personal.
He plunged in, leading a contact tracing effort that was crucial to ending the disease in West Point and other parts of Liberia.
And I'm proud to say, as a result of our working in West Point, we were able to develop a system to control Ebola to the point that the minister, Dr. Dan, called us and said, what you've done in West Point, can you do in other places?
He then helped found and lead a national effort to study the impact of Ebola on survivors.
I'm the lead scientist in Liberia for the Ebola natural history study. Particularly want to understand among Ebola survivors, what are some of the medical complications they develop. So we're looking at them and we're going to follow them for 5 years. They come by every 6 months. This is the largest study in the history of the world.
He has also helped lead the effort to establish Liberia's Public Health Institute.
So when Ebola ended, the Deputy Minister of Health came and said, I want you to help Liberia to set up the Public Health Institute. We wrote a strategic plan, operational plan. I'm happy to say that this going December, the House finally passed the bill, so the Senate passed the House. It's not going to be before the President to sign it. And what that will basically do is that we're going to put people together who will be able to detect diseases ahead of time and respond. And so we don't have our innocent people dying like what happened from Ebola.
But the thing he's most proud of is this: the Refuge Place Health Center that he helped build with his own funds while still a graduate student in the United States.
And my dad said, well, my last thing I want to do before I die is to ensure that all of you get land and build a house. I said, Papa, I don't want to build land and build my house. He said, what do you mean? I said, I want to build a clinic for the poor people. He's like, are you serious? I said, that's what I want to do. And I was a student then. I couldn't afford the money because I was living on the money they were paying me. As a graduate assistant, so they would give me like $850 every 2 weeks. I would live on the $850 I would send it. And so I bought the land in Lower Johnsonville for the people. I bought the land and built a clinic. June 2014, we opened the clinic. We started first running as a free clinic in Ebola. I think we've treated pretty close to 20,000 people now. We have pretty close to 700 deliveries.
He is now helping residents of low-cost village just outside Bensonville to build a similar clinic. And the lesson he thinks we can learn from all of this is rather simple.
Working with the local people in our community to address their needs is the power that can change this country. Because the local people, they want the same thing I want. They want their children to be educated. They don't want their children to die. Nobody will want their child and say, I want to die. They want their children to go to school and have a future. I show all the young people looking at me today want to be like me, want a success story too. So because they all want this, then we'll have one common thing. So my own thought is that we can do it all across villages and slums. We shouldn't write them off.
Well, that's our program for today. Thanks for tuning in. We'll see you next time on another edition of the program. So long, everybody.
Development matters. Development matters. If for you, if for me, development matters.